do is we're going to talk about the anatomy here a little bit. Most important thing you're doing when you do this procedure, and everybody really gather around so you can see this, is you want to find the thyroid cartilage, right? That's the big Adam's apple on men, or sometimes women, doesn't matter. But you want to find that. You can usually find that pretty easy. The one thing you don't want to get it confused with, it's a little higher up here, is the hyoid bone. It's actually a bone that's up here higher. Sometimes people feel that. It's like, oh, I found something that's hard. That must be what I need to make my incision down there. That's too high. You want to find the thyroid cartilage. And at most people, it's pretty mobile. This guy's relatively thin. We can actually see it. You get a larger patient, it might be a little bit more difficult. But grab it, and I usually grab it with my non-dominant hand because the procedure you're going to want to do with your dominant hand, right? You want to cut with your dominant hand. So I find that, I grab it, and then it's just kind of a shield-shaped cartilage, and I work my way down with one of my fingers. Then I want to find there's almost a little space in between down there, right below. And that's going to be the cricothyroid membrane. And immediately below that is the cricoid cartilage. So in between the thyroid cartilage and the cricoid cartilage, you have the cricothyroid membrane. That is our target. That's what we're going for. Now, if I make an incision that ends up going a little too low, it's okay. It'll still go in the trachea. You'll be fine. You'll essentially have a trach. Not a big deal. Where you don't want to make your incision is too high. The thyroid cartilage, it's really tough. And once I dissect some of this down, you'll be able to see it real well. It would be very hard to cut through that. But the problem is if you cut through that, and it's tough for a reason is your vocal cords are right behind that. So they're protected by that, and it makes sense. You don't want to cut into that. That would make a mess and cause problems. You want to stay below that. So you want to stay below the thyroid cartilage. So this is all anatomy, and this is all a midline procedure. You want to stay as much on the midline as possible and stay away from out here, because what lives out here? All your blood vessels and things, right? Carotid, jugulars, big blood vessels that are going to your head. You want to stay away from that. So the more you make this a midline procedure, the safer you're going to stay. There are some small veins that run in here, and there's a couple small arteries. It's okay if you hit those when you're doing this. It's going to bleed. It's okay. That's to be expected a lot of times. So again, want to find that cartilage. Want to hold it. I usually grab it with my fingers so that I know in case things are moving around with my non-dominant hand. And again, I feel with that finger. Now, there are two different ways you can do this incision-wise. If you're very confident and you have a thin patient like this, you can just do a completely horizontal incision through the membrane. And if you're not 100% sure, and the way that I actually recommend to do this is make a vertical incision longer than you need, and it gets you down a little bit, especially if you have a larger patient. Find that cricothyroid membrane for sure, and then make a horizontal incision, and that's the way I'm going to show you. And then basically what you're going to do is you can put your finger in the hole afterwards, followed by the bougie, and then you're going to use the bougie the same way you're used to using the bougie. Put it in there. A lot of times you actually can feel the rings, and it's going to hang up, and it's going to hang up a lot quicker than it would if you're coming in up from through the mouth and trying to do the intubation. And then, of course, your tube on. And again, 6'5", 6'0" is a good size to go with. And you just need to put it in far enough that the cuff goes through the hole. You don't need to go farther than that. It's a lot easier to write main stem, which is not the end of the world, right? You can always pull it back if that's the case, but it's going to be a lot shorter distance than it would be as if you came in from the mouth. So we'll go ahead and walk through the whole thing here with the incisions and all. So I'm going to do the vertical and then the horizontal because I think that's the safest way to go. So I'm going to start up here. I'm going to cut above the thyroid cartilage. I'm staying in the midline. I'm going down, just about there, generous incision. You can see fat. And what I'm doing now is I'm going to repalpate. Got my thyroid cartilage again, cricoid down there. Cricothyroid membrane is essentially right down here below. And then I'm going to cut, and I can feel that I've cut into a space. I can put my finger in there, or I can put the bougie directly in there. Now I've got hang up right there. One thing you don't want to do is, a lot of people don't cut deep enough. They make a false passage in the skin, and then it stays in the skin. Because most people are afraid to cut because the scalpel blade is not something you're using every day. So they're afraid to cut, so they make these little tiny incisions. They don't go deep enough. Most people aren't going that deep that they're going all the way into the esophagus. That's actually fairly rare. And then I want to follow this up with my ET tube. Sometimes you have to give it a little twist, just through, and then bougie comes out just like it normally would. I can throw my Untitled CO2 on there. And then, of course, we're going to confirm like we normally do. Sometimes you get a little leak right there. You actually even inflate the cuff too. Oops. But
Is this a sterile procedure?
At this point, no. I mean, once you're doing it for an emergency like this, you can splash some betadine on there, but it's not necessary. But we have Untitled CO2. You get chest rise. Patient should be easy to bag, and that's what you were looking for. And actually, we are still getting a number, like I said before, which is kind of crazy. This is a cadaver, but we are getting an Untitled CO2. We've confirmed now that we're in the airway with Untitled CO2. Patient's easy to bag. Getting good equal bilateral chest rise, and essentially that's it. And of course, you want to secure it just like you want to secure any ET tube. You can actually cut the ET tube and make it shorter if you wanted to with your trauma shears, as long as you stay above the cuff. The problem with that a lot of times is you get to a hospital, then they think that it's deep, and then they pull it all the way out. Because they're like, oh, that endotracheal tube is too deep. So I would leave it the way that it is, because that's what people are used to. But
secure it with a regular tube secure into those.
Yeah, or tape, something like that. But you can see, again, we're getting some Untitled CO2 cadaver. And actually what I'll do now is I'll dissect down a little bit just so you can see some of this anatomy. You can see some muscle in there. That's normal. That's, if I go above here. See, there's the thyroid cartilage up there. See how hard it is. But you can see there's no, I'm staying in the midline. There's the big Adam's apple. I'm right below. You can see this was softer. This was easy for me to go through. So if I try to put my scalpel blade through this, look how hard all the time I can't cut that. That's really, really tough. So if you're having a really hard time cutting, you're not in the right spot. Because I mean, that's super tough. And it's, again, it's made to be tough because again, it's protecting your vocal cords are right behind this. So that's why if you're cutting through something that's really hard and feels like bone, you're not in the right area. So that's why you want to reassess where you are. So it's very important that you find this. And you can see that's the prominence of the cartilage. Above, again, it's going to be soft up here because we're above the thyroid cartilage. This is where you don't want to make your cric. I went through the cricothyroid membrane here, and the cricoid cartilage is just below. Now, if I went a little lower into the trachea here, I have a trach. The patient's going to live. It's okay if you actually go a little lower than is necessary. But that's right through the cricothyroid membrane. And you'll be safe, again, if you stay in the midline, identify your anatomy. And I want you guys to come in here and really feel around. It's okay to cut through this muscle, but you don't see any big blood vessels in there, right? There's actually a little vein that's running right here. I stayed away from it. But if I'd cut it, it wouldn't have been the end of the world. It would have been okay if I'd cut it. But